Good afternoon and welcome everybody to the Injury Prevention plus Safe Environment for Every Kid, or SEEK, action period call number 1. We are in the 5th wave of SEEK and we are happy to have you. We want to thank our program partner, the Ohio Department of Health, VIPS section. And today's agenda, I want to welcome all of you. Some data collection tips from Zainab. We'll hear from Dr. Denny of SEEK program fame and her presentation on firearm safety. We'll talk about a little bit of QI and next steps. So in the chat, if you could please share your name and practice. And I'm going to launch a Zoom poll around holiday safety. Have you seen an increased, have you had increased holiday safety discussions with your families given the season? Okay, thank you for participating. There has been increased discussion around holiday safety in regards to adding it to your WellCare visits for the season. That's very important. And then getting questions from your families. That is very important and timely. Okay, Zainab, I have your prompt. Do you want me to stop sharing?
Sure.
Okay.
Can you see my slides?
Yes.
Okay, that's great. So first of all, I want to thank everybody for taking the time to submit baseline. I know we're still missing some data from a few practices. As Brooke mentioned in our individual calls, you know, there is a deadline, but we're very open. If you need more time to submit that, please take the time that you need. This will be reflected in the data that we'll be sending you every month. That will be updated with the data that you're collecting, the QI data that you're collecting. But what I'll be showing today is the most recent data as of last week. So you'll see, again, this is all baseline data that was collected. Again, thank you so much for submitting that. As you know, that we're collecting data for 5 metrics: social needs, family needs, home safety, car seat safety, and safe sleep. And safe sleep. And so again, this data is just going to be a presentation of the data that we already have. So we are looking at whether or not you're screening your patients, and of those that are screened and indicated that they have some sort of a risk identified, are those individuals being counseled. And counseling can involve, you know, whether you give them resources or you refer them to another physician, or you know, however appropriate the counseling is for that specific risk. So it looks like throughout baseline, it's hovering at about 50% of your patients are being screened for social needs. And a few of those are being counseled. And again, we'll be sending each practice their individual data, and if anything looks off, please let us know. But again, this is aggregate data for all the data that we already have. And so these individuals are being counseled. There doesn't seem to be a trend. It does fluctuate up and down, but really our focus is to try and increase these numbers throughout QI. And again, if there's any questions in terms of the data collection tool, or if you're unclear about something, please let us know as early as you can so that we can address that at the beginning. In terms of family needs, so if you know, if the parents are needing some help, if the mom has depression or the primary caregiver is struggling, then these are what's included in family needs. Again, it looks like it's hovering at about 50%. Usually for the lower age group, we're seeing higher numbers of screening, and we're also seeing higher numbers of counseling among those that are identifying risk, or those with an identified risk. we are seeing pretty much lower numbers for the older age groups of 13 months to 5 years. But again, our goal here is to kind of increase this throughout QI. Home safety is our third metric. Again, we are seeing higher screenings for the lower age group, but we're seeing a little bit of mixed, almost the same or equivalent counseling for both the younger age group and the older age group in terms of counseling for home safety. And home safety includes issues like whether or not furniture is secured to the wall, if they have if they have the number for poison control, if there's smoke detectors and whatnot in the home. Car seat safety and safe sleep, where I was pleasantly surprised to see that the majority are actually screening for car seat safety or asking questions about whether or not the car seat is installed safely. And then again, very high numbers of families are being canceled on car seat safety. And this is pretty much standard to what we've seen in previous waves, or what I've seen at least in the previous wave. Again, we're trying to increase these numbers as best as we can. We want everybody to be screened, whether or not they indicate that there's a risk is something else, but we still want everyone to be screened. We want everyone to be asked these questions, and of those that we have identified risk among, we want all of those people to be counseled. But again, the data here looks pretty good, and we can see the same for safe sleep in terms of screening with the younger age group, which again is consistent to what we've seen. At baseline, the younger age group is almost always being screened. And then of those identified risk, we're still seeing high numbers of counseling among the younger age group than the older age group. But again, we are still trying to increase these numbers. And I just want to thank again everybody for submitting that data. You'll be receiving your individual data maybe next week. If anything again looks off, please let me know. In terms of the data collection tool, we understand that sometimes it can be difficult to kind of manage your time with your patient. But if there's any questions that you have, again, if there's anything that we're sending you that does not look correct to what you believe your practice is doing, please let us know. We can go through the data together and sort of come up with where the errors are arising, what issues are causing us to see different numbers, or send you different numbers than what you think you've submitted. But again, if any questions come up anytime during QI data collection, please let us know, even if it's towards the end. But like I said, we try to address, or we are really hoping to address most of the issues in the beginning, so that as we continue through baseline, the majority of the data is collected correctly. If no one has any questions, I can hand it back over to Brooke. But if you do, please, either enter those in the chat, or you can go ahead and ask now. But that's what I had prepared for today.
Thanks, Zainab. Yeah, let's pause here. Any questions on the very initial preliminary results, or any questions on data collection that you haven't emailed so far?
And again, we appreciate you taking the time to pull QI data. If you're struggling in terms of time, or in terms of pulling that data, please let us know. We can definitely extend the time that you would need to give us that data. But it is very important, as you can see, for us to kind of measure the progress of our work and see how we are able to improve both screening and counseling for families that need it. So we definitely appreciate the time, and we definitely appreciate the effort that you're taking to submit this baseline data.
I agree. Thank you, Zainab. There's a raised hand.
Good morning.
Hi.
Hi. So as you know, I work with Hispanic patients. I have to be honest, I have been behind with my data collection, but I'm working with my residents. I will try to do the best. But I would say that time-wise in my clinic, where we have less than 20 minutes to fulfill everything, but I can say that I can do a best work, but I need some time to do that. How many days can I have the data to put in the system? Because I know that I have data collection from the last 2 weeks, and the baseline data for me was very difficult because we work with electronic record, and some of the patients that I worked before, I don't have the notes to how to track the notes in order to see what I did with these patients, but I have data that I can put as baseline. I don't know, is late to do that?
No, it's not too late, but I think because you have some special circumstances going on that you and I can talk offline and create a plan.
Okay.
Does that sound good?
Yeah, that's fine. I don't want to take more time, but thank you for that. Thank
Yeah,
you.
absolutely. We'll stay in communication.
Okay, bye.
Thank you so much. Okay. Zainab, thank you. This is a disclaimer from ODH around our presentation today. And Dr. Denny, I have your slides.
Okay, hi guys. My name is Sarah Denny. I'm a general pediatrician in Columbus, Ohio, and I've been involved in the chapter for many years around different injury prevention projects, including SEEK, SEEK plus injury, and I'm also the medical director of the Store It Safe program. So we're going to talk a little bit about firearm safety and how it kind of relates to the work that you're doing around other safety issues in this project. Next slide. Nothing to disclose. Next slide. I'm going to be going a little bit quickly because I do have a lot of slides, and I am very well aware that you guys are very busy in clinic and that there's other things. You may have questions, and there's other slides at the end of this. So if I'm going too fast, or if you have questions as we're going, please feel free to get yourself off mute and jump in with a question or put it in the chat. And Brooke, you can just interrupt. I don't mind. All right, next slide. So, one of the things is why are we talking about firearms? Next slide. And if you've ever turned on the news, if you've ever opened a newspaper, next slide. Next slide. We're seeing this every single day. So, these are some headlines around accidental shootings. Next slide. And again. But also suicide. So I'm going to be touching on both of these. I realize the SEEK Injury Plus SEEK program is geared more towards younger kids, but while we're talking about firearms, I think it would be amiss to not include something around adolescents, which you're obviously also seeing in your practices. Next slide. And there we go. Okay, so this slide, I'm hoping you may be familiar with, but for years and years and years and years, motor vehicle collisions were the leading causes of death in children and adolescents in the United States. And what this image is showing, this was published in New England Journal of Medicine last year, is that in 2019, firearm-related injury surpassed motor vehicle crashes as the leading cause of death. So if you weren't talking about firearm injury before, I'm hoping after looking at this graphic, you start talking about it, because I'm sure you're talking about child passenger safety, which is also very important for sure. But firearm related injury is now the leading cause of death in kids. So we've got to be talking about it. And hopefully at the end of this discussion and presentation, you'll feel a little bit more comfortable talking about it. Next slide. When we look at data from around the world, we know that the United States accounts for 91% of children killed by guns compared to other high-income countries. And we could probably spend about a week discussing why that is, but it is what it is. And so what can we do in the healthcare setting to help keep our kids safe? Next slide. Now, when we look at all injury mechanisms, there is definitely racial disparity, and firearm deaths are no different. When we look at the gun deaths in the United States in children and teens from under 18, we can see that the rate of death in Black children is far higher than white children. So again, thinking about just like racial disparities, socioeconomic disparities as it relates to injury, this is just one more example that we see in the data. And this was just published in April of 2023 by the Pew Research Center. Next slide. Okay, so, what is the reality? Next slide. We live in the state of Ohio, where we know that more than half of the homes in the state have guns. So the kids that we're seeing in clinic, many of them are living or spending time in a home where there is a gun. Next slide. We know that kids as young as 3, and some would even argue 2, have the ability to pull the trigger of a gun. Next slide. And we also know that kids are curious. They're mobile, they're curious, they can get into trouble like the minute you turn your head. And then we know our teenagers are impulsive and emotional and can make some really life-changing decisions in a short period of time. Next slide. So, I really feel like these are probably underestimations. This nationally, over half of all homes have a gun. When we look at Ohio, 37% of households report a gun. Again, I believe to be an underestimation. 46 report that their gun was in an unlocked location. So that's a really significant number. And so that's why this really needs to become part of our discussion around safety, home safety, child passenger safety, and we just roll it into that conversation because it is all part of keeping kids safe in the home. Next slide. Now, when we're looking at fire, so, in young children, we have the accidental shootings, which we see, unfortunately, all too often. And when we're looking at firearm homicides in young children, it's more likely to be intimate partner violence related, for the child to be a bystander or there to be some sort of family conflict going on at the time of the shooting. Next slide. We're talking about accidental shooting in young children. Most often the shooter is also a young child. And typically the scenario is that they're playing with a gun, and most often it occurs within a home, whether it's the child's home or someone else's home. Next slide. Now, this was a really interesting study that was published in the Archives of Pediatric and Adolescent Medicine. And what they did was they took parent-child dyads and they separated them, and then they asked them questions around different safety things, but specifically for the purpose of our discussion today, around guns. And what they asked them were things like, to the kids, do your parents have a gun? Do you know where the gun is stored? Have you ever touched the gun? And then they asked the parents, do you have a gun? Do you think your child knows where the gun is? And do you think your child has ever touched the gun? And the results of the study were that parents have major misconceptions about what their children know and what their children do. So kids as young as 10 were just as likely as the older children to know not only that their family has a gun, but where it's located and have handled the gun at some point. So 40% of parents incorrectly thought that their child did not know the location of the gun, and 22% felt like their child had never touched the gun. So kids are smart. They know better than to touch a gun, but they do it anyway. So even if, you have a family who's like, oh, my child knows all about gun safety, that's great. But we still need these barriers in place to keep the kids from getting access to the gun. And that's what we're going to talk about today. Next slide. All right, so, actually, let's go on to the next slide. We decided in the state of Ohio that we were going to bring together a lot of different partners who come from all different sides of the gun issue and just have a conversation to find some common ground. What is something that we could all agree on? And what is some messaging that we could all share to try and keep kids safe? And so the Partnership for the Safety of Children Around Firearms was established. Next slide. And we were really specific in what our goals were. So we wanted to come together and talk in a very non-divisive way about gun safety, and then determine a very simple message that we all felt like our organizations could buy into, that we could continue to share to promote safety. So sort of like click it or ticket, we wanted our message to be something that was succinct, clear, and that we would all be able to share. Next slide. We really wanted to focus on unintentional firearms related to injuries and death in children, and then suicide of teens due to firearms. Next slide. We did not want to talk about, Second Amendment, lack of mental health services. We really wanted to stay very laser focused on those two issues. And we had this group of people that was absolutely fantastic. We had military, we had pediatrician gun owners, pediatrician non-gun owners, law enforcement, concealed carry instructors, gun retailers. We just had a wide variety of people that we brought to the table. We were really clear about establishing some ground rules from the beginning, and we had a fantastic conversation. And what we learned was that among gun owners, there can be some distrust of the medical community. Depending on how the questions are asked, they often feel judged, and they also fear that the EMR is also a form of registry. But at the same time, they were super open to having a conversation. They're open to hearing safety messages from their healthcare provider, but that it was all in how we approached the conversation as to how open and receptive that they felt like they would be to that safety message. Next slide. These are just a few of our original partners. We were really fortunate to have this great group of people that continue to remain engaged in this work. Next slide. And so, from those discussions that we had, and from talking about this for many years, some tips that we have for healthcare providers is just making this a part of your normal safety conversation. That makes it seem like less out of left field when we're talking about guns. And they're like, wait, well, you're my doctor, why are you talking about guns? It makes it more of a natural transition into the conversation. So we're talking about medication storage, we're talking about smoke detectors, we're talking about car seats, we're talking about gun storage. And then the other thing is operating under the assumption that everyone has a firearm, and then framing your discussion that way. Because again, the fact of the matter is, if the family doesn't have a firearm, the child is probably spending some time in a home where there is a firearm present. Next slide. So, similar to how when you're talking to your asthmatic patients and their families, and you're talking about controller medications, instead of asking, you don't miss your controller medications, do you? I mean, that's really leading and kind of judgmental, but instead, like, how many times a week do you miss your controller medication? That acknowledges the fact that I get that you miss your controller medication. I'm trying to have a dialogue to figure out, like, how much are we missing? Is there something we could do differently? That kind of thing. It's the same with a gun. Instead of, do you have a gun? And you're sitting there with your EMR, entering in that information, framing it differently. If there's a gun in a home, is it locked up? And I would really encourage you to say, is it locked up, as opposed to, is it stored safely? Because what I consider to be safe and what someone else considers to be stored safe is very different. So, yeah, it's under my pillow, it's stored safely. To me, that's not keeping a child safe. So being very specific in what you mean, is it locked up? And if they say yes, then I think that's an opportunity to be like, great, that's fantastic, positive reinforcement. What about other homes where your child's spending time? If they say no, then you can provide some education around safe storage. And then if you have it available, provide them with a gun box. And if they say, well, we don't have to worry about that, we don't have a gun, still encourage them to talk to their child about gun safety, because again, their child is likely going to be in a home where there is a gun present. Next slide, please. So, that's kind of the focus on the younger children. When we're talking more about our adolescents, it's important to recognize the fact that suicide is the leading cause of death in people 10 to 25 years old in our country. These rates are continuing to rise, and our emergency departments are just inundated with adolescents who have attempted suicide, or having suicidal ideation, or having a mental health crisis. I think it is no newsflash to anyone on this call that we are experiencing a mental health crisis and we have a significant lack of resources. And so in the primary care setting, it kind of falls to us, and we're doing a lot of this management in our offices. Next slide. So when we look at youth who have completed suicide by firearm, 82% of those youth used a gun from their own home. Next slide. What's really critical when we're thinking about keeping youth safe from suicide by firearms is a barrier. There was a study done where the researchers interviewed survivors of suicide attempts, and they asked about how much time elapsed from when you decided to take your life and when you attempted. And 50% of the survivors made their attempt within 20 minutes of their decision to attempt suicide. So if we can delay their access to lethal means, whether that be pills or guns, if we can delay that for 20 minutes, 30 minutes, an hour, we can potentially get that person through that crisis before they take their own life. So that's where the barrier and having that lockbox is critically important, because time is of the essence. If we can just buy some time, we can save lives. Next slide. Next slide. So if you have not already seen this, this is a fantastic resource. This is the American Academy of Pediatrics Blueprint for Youth Suicide Prevention. I'm not going to go through it in a lot of detail because I know this is not the focus of this learning collaborative, but I wanted to point out a few key things here. One is that health clinicians are well positioned to identify and support youth at risk for suicide in any type of clinical setting. When we look at the data of kids, youth, and young adults who complete suicide, many of them have had an encounter with the healthcare system within 4 weeks, even the week of their death. So how do we do this? Universal screening. So screening for depression and suicidality at all well child visits for our adolescents. Having a standardized clinical pathway. You guys are doing quality improvement in your practices, so you understand that if you have a standardized process, things don't get missed. So same thing goes with your clinical pathways. Okay, we're going to screen all these people. If we have, if a screen comes back like this is what we do, and having that pathway laid out. And we have some resources that can help with that I'll go over in a minute. And then leveraging the strength of all members of the care team. I mean, we're all super busy, right? We have busy templates. Our patients have a lot of needs. And so how can you use other members of your care team to help with this work? Whether it's your social worker, if you have an integrated psychologist, how can you use other people to help you as you're supporting these youth? Next slide, please. Okay, so this is kind of speaks to what I was just talking about those contacts before with the healthcare system. So 80% of adolescents visited a healthcare provider within a year prior to their suicide. 50% had visited an emergency department within that year. 40% had contact with their healthcare system within the 4 weeks before their death, and 30% of kids 15 and up had contact with the healthcare provider in the week before their death. So if we are not screening, we are not going to be able to identify these people. Next slide, please. Next slide. The other thing I'll say is that depression screening is not adequate. It misses a significant number of people who are suicidal. So you can be suicidal but not be depressed. So you need to be screening for both. This is an example of a resource for providers on the front. It talks about, what is Store It Safe, talking about how to have some of those conversations, some resources for providers and families if there is a crisis situation. And then on the back is just an example of kind of what that clinical process I talked about, on that blueprint, having a standardized clinical process. Here's an example of one. Now, is this going to look the same in every office? Absolutely not. But this is an example of what it could look like in your practice. And then also, you know, if someone scores mild, what might your process look like? And then also for your ASQ, which is what we use for suicidality screening, you know, what do you do with a positive result? There's also some additional information. You see those QR codes there. One is a safety plan. So safety planning is a really great strategy that you can do in the office. And then if you are not familiar with the ASQ, which stands for Ask Suicide Questions, it's a very brief 5-question questionnaire that assesses for suicidality. There's an entire toolkit. The screen is available in like 12 languages, a toolkit as to how to implement it, resources that support it. So those QR codes are very, very helpful. Next slide. And then resources for parents. So just providing some information on storing firearms safely. And then for our parents of teenagers, talking to them about crisis planning. So planning for a crisis before it starts, knowing what to do in a crisis, making sure that a teenager does not have access to a firearm. So, you know, we have kids who hunt or, you know, shoot for sport. And so they know a lot about firearm safety, but if that child has access to a firearm when they're in crisis, that can be a deadly situation. So how do we restrict that access? So this is a really nice handout for parents and caregivers. Next slide. And this is really for how do we manage our child in a mental health crisis. And so some really effective in the moment strategies that families can use. So this is like, if you want your families to know like one thing or, you know, the most essential things during a mental health crisis, this RAC card has got all the information you need. And then there's a QR code that provides a link to our digital family resource, which just goes a lot more in depth. So if families want to learn more, they can easily access that information. But we wanted to make this RAC card like the absolute most essential information for families. Next slide. And then this is a new resource developed in partnership with the Ohio Suicide Prevention Task Force and LifeSite Ohio. They asked us to create a resource for firearm owners. So this talks again a little bit about the data and then talks about different storage methods and, you know, just some data to help guide them in their decision as to how to safely store their firearm. Next slide. And then this one is for youth, specifically teens, that talks about, you know, sometimes you don't feel great and that's okay. What are some ways that you can feel better? What are some things to do if you're feeling down? What are some signs of suicide in your friends? What do you do if a friend confides in you that you're feeling suicidal? So I really like this one. I use this one a lot because I feel like it's a great way to sort of break into that difficult conversation with families about suicide. And then also really encouraging families to be doing frequent check-ins with their teenagers. You know, if your child is captain of the football team and valedictorian of their class and seems great all the time, you still need to be having these conversations, not just if your child has a history of depression, has a history of anxiety or some other mental health issue. This is for all teenagers. They all experience, you know, ups and downs with their emotions. Seemingly small things can be considered a crisis situation for them. And we know they're impulsive and don't always make the best decisions. And so, you know, encouraging families to have recurring conversations and check-ins with their teenager. Next slide. This is the digital resource that I mentioned already. It actually has a different format now, but similar content. Next slide. Okay, Brooke, I'll turn that back over to you.
Thank you, Dr. Denny. This is just a nod to the resources that you have in your hand being enrolled in the program. It's the Store Safe information that's on the SEEK Caregiver Resource handout. That should look familiar to you. And then the Seek Provider Talking Points also have a firearm safety talking point section, authored in part by Dr. Denny during her time here. So you are armed with talking points and resources that when you hand the resource, the caregiver handout resource to your families, they are getting all that information, even if you didn't have time to talk about firearm safety during the visit. They are walking away with firearm safety tips and a link to the Store It Safe program. Any questions for Dr. Denny? And I'm curious to hear if anyone has any stories firsthand from their practice around firearm safety. We appreciate that the 0 to 5-year-olds may be in the face of firearms, but they also may be living in a home where there is a teenager that is in crisis. So all of that applies here.
Yeah, I definitely had some experiences with families having some resistance, first acknowledging that there were guns in the home, but very kind of judgy and like, well, why do you want to know that? What are you going to do with that information? So glad to see that your interactions were very similar to what I've experienced.
Dr. Denny, could you speak a little bit to maybe a little bit of scripting, if there is some pushback, if there is some hesitation, if there are a lot of questions being asked, like the appropriate few things to say at the beginning to start that conversation?
Sure. So, I mentioned kind of like how to kind of break into that conversation initially. And then, depending on what age group you're talking about, one of the things we say with our adolescent population is, just like we talked about safety things when, Johnny was little, the safety issues change as the child gets older. And so, it's really important that we talk about, these particular issues today. One of the keys is really just like, depending on, how they're feeling, how resistant they are, is just, trying to align your allegiance with the family. Like, we're all on Team Kid, right? Like, I know that you want to keep Johnny safe, and so do I. And so I just want to talk about some strategies. And then maybe you can like roll it into talking about drowning, at the same time as guns. And if it's really becoming kind of adversarial, asking, just, do you mind if I provide some safety information? And they don't have to answer the question, right? Like, whether you have a gun or not doesn't matter. I just want to share some information that I think might be helpful for you. And then, you can share the information and they can do with it what they want. And then just a plug for our Store It Safe Quality Improvement Project. We've been really working on how to have some of those conversations using virtual reality, like a virtual reality avatar role playing, and that has been incredibly helpful because it's all different ages, talking about it with parents of young kids and then adolescents and then some of the more resistant parents. And so just giving you a little bit of practice on how, like, what feels right to say, or gives you a chance to kind of practice some of that, and that has been incredibly helpful as well.
Practice, right? Any other questions or scenarios that you would like to share? Yes, thank you, Dr. Denny. Okay, hearing none, Dr. Denny, you're welcome to roll off or stay on, whatever you prefer. But I am a conduit for any questions that you think of for Dr. Denny in the future. Thank you for the good information. Okay, we have time for QI Corner here. So as you are implementing your program in the same vein as kind of the clinical pathway, we want to think of kind of the program implementation workflow. So you are familiar with workflows in your protocols. We want to make program implementation as simple as possible by implementing a workflow here. So you have already done some of these, but you are testing the screening tools and the feedback survey, starting at the beginning and going all the way through the end and pushing that submit button to get your data captured. Review your current workflow during well care visits. It's been acknowledged today that there is limited time to do so. But in implementing one more thing into your template and into your conversations is challenging. But if you create a workflow, maybe it would be an easier process getting started. No problem at all, Dr. Parisa, thank you. What SEEK topics are you currently being counseled on? What are you currently talking about? What are currently in your template? What can you add that's part of the screening tool to your template to make an impact on your patients and families? What practice staff will be looped into the program? That's also a nod to the pathway. Your nurses, your MAs, your PAs available. Is there a dedicated place for you to be able to put your SEEK resources? So you'll have your tangible resources soon, and you have your paper copies of the resources. Really important that we're sharing kind of that family handout at least to every visit with your patients and families. Get the resources in their hand, and they will be able to review it after they leave your office. And then the next slide will reflect a workflow and example and template that is available for your review. And I see a hand raised. I'll pause here. Any question from iPad 6? Okay, I can always come back around. So this is a example of a workflow graphic that is from a different program. But if you work better in kind of the visual realm and being able to build out what the steps are going to be to make implementation for SEEK as seamless as possible, we can work together to build one of these. I'm sure you're doing the steps already, but maybe haven't put it down on paper. But if it's helpful to train your staff or get more of an idea visual around what you are working on or how you would want to change anything as you go through. So that's what the PDSA cycles will also be. You start with something, it may be not working to the best of its ability. You need to tweak a little bit. You need to train your staff differently. All of that can be a PDSA cycle going forward in the program. And next steps for the program, we will talk about if you have special circumstances completing your baseline data collection. But for those who have started it already, we're asking that you complete it as soon as you can. Please begin or continue the SEEK screening tool implementation. That will be using the iPads in your office. Start thinking about drafting your first PDSA, and we will talk about it in January. If you know your January schedule, let's schedule your January coaching call. We'll have more information on your data, conversation about your PDSA cycle and kind of how you want to go forward. Any wins, any barriers, conversations that you've had with your families. All of that we'll kind of take a pause in January and ask about how things are going. And then the next action period call will be Wednesday, January 10th at noon. And just like this one, all calls are recorded for on-demand viewing, which makes for a flexible program that if you can't make it, you can review it later. And any questions on what we covered today? Okay, hearing none, I can give you some time back, but if you think of any questions around anything, data, program implementation, firearm safety for Dr. Denny, the resources that you have, maybe it is helpful to take a look at what all the line items that are on the family resource handout, become more familiar with what you're passing on to your patients and families. That might be a good tip too. But if not, we will see you all in January. Thank you so much and have a good holiday season.